Thank you so much. Such an amazing conference with 170 people and teams. This is great. I'm Radha Sudram, and I've had the privilege of organizing this conference along with Winnie. I have to make a confession now. I'm having a total fangirl moment, and I don't want Professor Randhawa to blush, but he's the reason why I've continued to do the work that I do in this space. Professor Randhawa needs no introduction. He's a leading voice on health equity, organ donation, and end-of-life care across diverse communities. His influence stretches beyond academia, as you can see, because there are so many of us who are just ordinary citizens in society, but have wanted to join the civil movement to improve health and across all diverse communities. So without further ado, I'm going to hand you over to Professor Randhawa.
Thank you, Radha, for that very generous introduction. Much appreciated. So firstly, thank you to Winnie and colleagues for convening a fantastic program. This is essentially going to be my talk that although I think there is room for progress, and we've already started to talk about some of those issues this morning, what I want to set out to you is actually in terms of inequalities in the UK, in terms of organ donation, yes, absolutely, there is room for improvement. I don't want people to think there isn't. But if you compare us to any other country who's trying to tackle inequalities, no one's doing it better. And that's for many reasons, and I'm going to set out those reasons. So, and I'm going to use the metaphor of the journey a lot. So, like any journey, you need to have different stepping places and different destinations, and you need companionship. So I want to talk about many of the companions who've gone on this journey. So in terms of data, some of you will know this anyway. This is just a map of Europe, and it just shows you the different minority communities that we have across Europe, and obviously the UK. We've got a very large population from different countries. And this map just shows you where those people are from. So, for example, I do this normally as a quiz with my students and I reveal different countries. So many people don't know that the largest immigrant community in Italy is actually Romanian. In France, it's Algerian. In Spain, it's Moroccan, etc. In the UK, it's Indian. And this data is important because this will link to the sort of messages and messengers that other people have highlighted. So one of the key things we need to focus on is the UK is the most diverse population in terms of ethnicity across the world, and those population projections are likely to get a lot higher. And in the next 20 to 30 years, we're going to have a global problem that Renata has already alluded to. So when you now look at this data, which people have sort of talked about in different ways, when we look, this slide just shows you people who are opted in, opted out, the waiting list, and then donors. And this is where the whole systems problem manifests itself. So I want to focus firstly on people who are on the waiting list. So this should worry us as a country. The fact that 1 in 3 people are on the waiting list for a transplant in this community from a minority background should be of great concern, because as Renata has already mentioned, the fastest growing parts of the British population are the minority communities. So this, if left unchecked, is only going to get worse, not better. So this issue needs to be thought about, both in terms of how do we get more donors? Absolutely. But also, why is it that so many people from minority communities are on the waiting list? Because many of the conditions, long-term conditions that people live with, are actually preventable, treatable, and manageable. But clearly, we haven't solved that as a country. And it's something we need to reflect upon. And what does our research show? So I'm very lucky. We have a range of funders who fund a whole systems research program. And what it shows is that many people from minority communities and this is South Asian, African, Caribbean, and also we've been doing some work with the Polish community, who are a very fast-growing community in the UK. They're at much greater risk of diabetes, high blood pressure, kidney disease. And when you go across the dialysis units across the country, we see a far more greater number of people presenting with dialysis needs. And then you see people, sadly, now going abroad for transplants. Now, firstly, I would say that shouldn't surprise us because many people go abroad for medical treatment. But what should worry us is when people engage with transplant tourism, which is potentially buying and selling of organs, which obviously is illegal. But we can only solve that if we solve the issue of the fact that at the moment in the UK, if you're from a minority background, you do have reduced opportunities for transplantation. And to make things even worse, when you look at end of life care, where we have a whole research program, that's not very good either. So there's a whole systemic set of issues ranging from prevention of long term conditions all the way to end of life care that's just not very good. And when you want to solve these issues, you do need to think about, and you have to step back and not just think about organ donation, transplantation in isolation. You have to ask yourself, why are there higher rates of diabetes in minority communities? Why is the risk of kidney failure progressing from diabetes much higher? Is that about later diagnosis? Is it later referral? Is it poorer patient understanding? Is it poor end of life care? And why, obviously, the shortage of organ donors? And we've done lots of research. And by the way, all my slides are with you. You are welcome to have them all and use them as you feel appropriate. So we've done lots of research on the sort of diabetes care pathway. And essentially what this shows, it's a bit sort of highlighted with a star. It's actually no different than organ donation. Communication and engagement is key. And unless you have effective communication and engagement with people early on in their long-term condition, be that diabetes, blood pressure, kidney disease, people then don't manage their condition appropriately. So we've got to get communication at the heart of this. And then again, if we look at family consent rates for organ donation, they're not brilliant in this country. So for the white community, sitting around 65%, for the Asian and Black community, nearly half that rate. And also when you look at waiting times for kidney transplant, again, much higher waiting times for minority communities compared to the white communities. So this is why we have to take a whole systems approach. And I was so pleased that many people have already started to talk about this in the morning session. So we can't really talk about organ donation and transplantation, in my view, unless we're willing to talk about long-term conditions. And I'm so pleased, I think it was Winnie who talked about silos. Well, I'm afraid the NHS is a fantastic organisation, but we're also very good in the NHS at working in silos. So the kidney team in the Department of Health operate separately from the NHS blood and transplant team, or operate separately from the people who manage hypertension in Department of Health and Social Care, who operate separately on people who manage cardiovascular problems in the Department of Health and Social Care. So therefore, there isn't that connectivity when people are building messaging around engaging with different communities about better management of long-term conditions, but also how do we then build trust around organ donation and transplantation? So that's one issue that we need to think about. Then workforce recruitment, I think it was Candice and Torquazy who talked very eloquently about this. If you don't have culturally competent recruitment processes, you're not going to have a diverse workforce. And even if you do, if you don't train your staff to think about cultural competency, they're not going to operate in a culturally competent way. And I would be interested if it exists. If I were to take a deep dive into NHS blood and transplant, and looked at your sort of EDI issues for staff, would they be any different than any other NHS organisation? So we run a programme of research looking at diverse workforce issues in the NHS. And what we see time and time again is it's much harder, despite having the same qualifications or better qualifications for minority communities to reach jobs in the NHS and then to progress through those career jobs and to even achieve pay parity with their colleagues. And all of that is systemic because that impacts then on how policies are made, how strategies are developed, and then how issues like public engagement is progressed or not. So I think Orion had a slide very similar to this, but this is just some of the work that we've done with different communities. And I won't run through these slides in the interest of time, but I love this first quote because this was actually said to me when we were doing this research. So we were asking people about organ donation, and somebody said to me, "It's funny you found me now. You need my organs, but where were you when I had my high blood pressure, my diabetes, my kidney disease?" It's a really good point because if we're not out in the communities helping people to manage those conditions, why do we genuinely think they're suddenly going to say, "Oh yes, I must talk to you about donating my organs"? I'm being facetious to make the point, by the way. At the time of death, or donating a kidney while I'm alive. Because if we've let people down time and time again throughout their life, why do we suddenly expect them to engage? So this is why we need a whole systems approach. We cannot expect people just to think about organ donation transplantation if we're not getting other parts of public services to work for them. So other people don't trust the healthcare system, so they worry about, maybe doctors finishing them off before they're dead. People worry about religious leaders, life after death. And we've tried to translate some of this into sort of staff training, thinking about how do we support staff to correct some of these issues. So how do we ensure that families aren't worried about racism, aren't worried about burial or cremation being delayed, or if it is going to be delayed, we're honest about it. And we talk about religion. So as academics do, we built some models about how best to engage with the public. And really what we need to do is to focus on how organs are retrieved. So will the person really be dead? What will the body look like? Will the funeral be delayed, cremation be delayed, and where will organs go to? And that's a big issue. And I want to spend a bit of time talking about trust because we've managed really to skirt around this. So I'm going to be quite provocative, and apologies if I offend anyone. It's not intended. So we're living at a time where actually trusting government, not just in the UK, but in many parts of the world, is lower than it ever have been before. So that's any member of the public, let alone a minoritized member of the public. Then, if you are from a minority background, including myself, we've had 2 consecutive summers of violent race riots. We've had this ongoing debate about immigrants and migration. And I think it was last week, there was yet another survey showing that the amount of racist abuse to minority community staff members in the NHS is higher than it's ever been before. And you can't ignore that. It's foolish to ignore these issues, that we're living at a time where if you're from a non-white community, you probably feel more vulnerable than you ever have done so ever in your life. And to ignore that when thinking about organ donation and transplantation is, and it's my language, it's foolish. So you have to build that in. So it's not that you can't do something about it, but it goes back to this whole point about building trust and building messages. But to ignore the politics of a country and the politics of race and the politics of race identity at the moment, we do so at our peril, because we have to tackle those issues. And the only way to do it, and many people have talked about this already, is to think about trusted messengers. So these are people who I've had the privilege of working with over many years. So these are people who are impacted by this. So either living donors, donor families, a transplant recipient, community leaders. And you have to have, I think it was as Yasser said, you need the right messenger for the right context, because not everybody may be of faith. Some people will be. So you have to think about this and build trust. And we've already heard from Kirit and Orin, but I just do want to pay huge homage to their efforts personally and for many people they work with. They've shown great leadership over the years. As part of the NBTA Alliance, but also faith leaders have. So this image is 11. So believe this or not, this is a combination of work we did post organ donation task force. This was the first time faith leaders had been brought together in the UK, other than on Remembrance Day events or on security issue events. So let that just sink in. We have a history in this country of not bringing in faith leaders at national level unless there's a security issue or a Remembrance Day issue. So I think, hats off to NHSBT where it's due to bring in faith leaders to start this journey around organ donation is fantastic. And that led to the Faith Engagement Action Plan. Here's Rowit being fantastic as ever, engaging with the faith media. We've done some fantastic work as a country in thinking about ethnic case studies. We have to think about different audiences. So some audiences, they may not be of faith, but they may engage with media. So this is a Bollywood film star. Some people may engage with sports. So this is the England-India cricket match, national TV news, politicians, like them or not, it's very important. So here's you got the minister at the time stood next to a donor family and a recipient, so the wonderful Fiona Loud. But it's really important to have the visibility of the donors. So here, the only donor charity to ever receive a Royal Award is the Mandeep Memorial Foundation, and that family continues to do wonderful work. And it's a wonderful accolade for them that they got the Queen's Award for voluntary service. And we've seen this great work around community investment launch, which went on to morph into now the community grants program that Mark talked about. And again, it's been wonderful to see how different people have engaged with this. The amazing Abiola Action on Blood, they've engaged using hairdressers. They've even gone on to produce a film. I think Mark's already alluded to this wonderful work that my colleague Britza and many others have led at Hospital Art Studio, working now on arts and organ donation, but also our students at the university have led. And there's no reason why every university across the world couldn't do this, where students become ambassadors for organ donation. We're engaging with our council because councils have big reach in communities. So again, there's no reason why every university could not be partnered with its local authority to do this kind of work. And we've sort of engaged with the media. When we do freshers fairs, we now run a freshers event around organ donation. And again, these are approaches that everybody could emulate. And I just want to go back to this point that I think Kirit made so well. It's so important that we have an organisation like MBTA partnering with NHS Transplant. This was the event done recently. Just to sort of finish off, I think it's really important, despite what politicians say, as humans, we've always been social creatures. So humans always travel and always have done. If you go back to history, go back centuries, and always will do. And Europe, it will look very different, as Renata's alluded to. So we've got to be ready for that. And so, because of the fantastic work the UK has led on around ethnicity, so I think we forget that many European countries, they can't even collect data on ethnicity. It's illegal in many countries. So, the fact that we have data and we're willing to be critical about it and say we want to do better is fantastic. But other countries, they see us as, world leading on this area. So I'm doing some work at the moment helping Barcelona think about this because they've got similar issues now with their different migrant communities around organ donation. And now they're beginning to produce resources to engage with their different communities. We're also working out in the Middle East on these issues. And Brit's, I don't know if he's on the session today. He's done some fantastic work comparing different states in India because there's huge variation in the vast country of India, and why wouldn't there be? Because each state has a different history between its government and local public, and the healthcare systems are different in different states. And he's done great work. And then Asma, who's doing similar work with migrant communities in Qatar. I do want to, again, be provocative. So some countries are better at political leadership than others. So this is the Crown Prince of the Emirates. So he not only was kind enough to take a copy of a book that I wrote, but he signed up on the organ donor register, visibly did that. And on the back of him doing so, so did many people in that country. So, we shouldn't be asking of others things that we wouldn't do ourselves. So I think there is something about what leaders do in any country. Again, I just want to give a nod to the Al-Madi Institute, who had the foresight to publish this book, Organ Donation in Islam, that I was lucky enough to contribute to. And this is serving as a toolkit in many countries now to provoke debate, because it's the first book that actually sets out the different positions within one religion around organ donation. Because again, it's too simplistic to say, what does Christianity think, or what does Sikhism think, or Islam think? Because within each faith, there are different interpretations. And it's important to explain those interpretations so each family can reach their own decision. So Yas has been the driving force of this. Hope you won't mind me saying so. So Team Margot and many others who provided the secretariat to the all-party parliamentary group on ethnicity, transplantation and transfusion published this report in 2023 about where are our nation's donors. And that is a question you've got to ask yourself. We don't see many of our media really drowning us in imagery or stories about organ donors. And that's a difference, if I'm being blunt, between us and Spain. So when Spain ever has a media story about organ donation, it's always about the donor. Very rarely talk about recipients, very rarely talk about people waiting for a transplant, but they're constantly churning out stories about donors. So it's normalized. The act of donation is normalized in that country. And this is what I'm currently working on. So Kirit talked about there needs to be much more faith leadership. So I have the privilege currently of working with the Vatican on a project sponsored by the Pontifical Academy for Life, where we're bringing together all the faith leaders from around the world to start thinking about how do we have a global faith dialogue so that in every country, faith leaders are visibly talking about organ donation. So just to finish off, these are the sort of questions I would sort of ask us to think about. If we're really going to think about this as a system, what is the message? Who are the messengers in any country? How do we build trust? Because the answers for that will vary in each country. And how do we ensure visibility of donors? Because if I'm honest, in this country, donors are not visible. I compare it with Qatar. Qatar, every year, their royal family host an event to honour organ donors. All their media feature it. We don't do that as a country. And should we engage with the dialogue around the whole kidney care pathway, prevention, management and treatment, as well as organ donation, And where are role models? Where are these influencers in supporting us on this organ donation journey? And at community level, we want the schools, the colleges, the employers, everybody to be thinking about organ donation. So I've done this at pace. Like I said, all my slides are available, and happy to take questions.
Thank you so much. I mean, I think the takeaways for me are to be proud of what we've achieved in the UK, but also recognize that there are so many lessons to be learned. And thank you so much for that. So from talking, I think we'll probably have some questions during our panel discussion. And in the interest of time, I'll move on to speaking, introducing Elizabeth Warrington and Rachel Kasanji, our two specialist nurses in organ donation. So from the academic rigor that we've heard, it's down to the actual sort of people who approach these families in a respectful, compassionate, and patient and family-centered way. It gives me great pleasure and privilege to introduce Rachel and Elizabeth, who are going to share their experiences with family approach. Winnie's going to share the slides. So I think Rachel was going to go first. So Rachel, over to you.
Apologies. I think we've got the slides now.
Yes.
Hello, can you hear me?
Yeah, we can.
Yes, I am on the call. Oh, thank you very much for organizing this lovely conference. I'm Rachel from the organ donation team in the London team, and my presentation today is about the gift of life and consent challenges that we get in London. But I wanted to point something really important. There are many reasons why consent is a challenge in the London area, as well as cultural reasons in London. We have the most pediatric ICU in London. We have many major trauma in centers in London and specialist centers. So in most cases, many of our families, they travel a long way to come to London to visit their loved one. And just the long travel distance can cause additional stress to families and sometimes lead to relative refusal in some cases. But for today's presentation, I'm going to focus on the cultural challenges in consent conversation in London. Next slide, Winnie, please. Thank you very much. So this is an overview of the London population from the 2021 census. So looking at these snapshots, London has the most diverse population in terms of religion, ethnicity, and languages. So in 2021, almost half of the population of London was from the minority ethnic, which might be more now if we do another census, but it can tell you how much diversity in terms of minority ethnic in the London area. So following on the next slides from this one. So this is, Winnie, could you move on, please? Thank you. So this chart is looking at the 5-year data for deceased donors, living donors, number of transplants, and number of the number of recipient on the transplant waiting list for the minority ethnic population. So when we look at it, this is a 5-year data from 2019 to 2024. So the challenge here, as you can see, is to bridge the gap. So this gap, which is highlighted in purple, is between the recipient and the transplant list. And the big gap between, which is highlighted in pink. So we're trying to bridge this massive gap highlighted in pink, which is the difference between the transplant list and the minority donors. So even if we combine the living donors and the deceased donor, the gap is huge, as we can see here. On the next slide, so I've looked at the comparative consent rates in terms of donation for brainstem testing and donation for circulatory death. This starts from 2021, April and September 2025. This comparative rate is between the white population, whether within the London area, and the minority ethnic population. We can see the trend here when we compare the rates, whether it's the donation after brainstem testing or donation after circulatory death. The trend looks almost the same. So half of the minority ethnic donors. So basically, the consent for the minority ethnic is less than half of the white population. So this is why we're working so hard. There's a lot of community work that's happening to help bridge this gap. So in 2024, so last year in June, Winnie, do you mind going to the next slide, please? So last year in June, there was a survey conducted by one of our London specialist requester, which really looked at this, the specialist nurses' experience in approaching minority ethnic. So she sent a survey to all the specialist nurses throughout the UK. And according to this survey, these are some of the common, challenges that came from the specialist nurses. When I looked at it, most of them are, interlinked. So I don't want to go into details into each and one of them, but when we see in terms of involvement of families abroad, so so many minority ethnic families, sometimes the next of kin is here in the UK, which in most cases they're spouses, but then they will want to call the families of their spouses abroad to get the consent. And because of organ donation practice in their countries of origin is not legally, there's no legal platform for organ donation. Many people don't know. When you're waiting to hear information from people back home, usually it will be a no, or sometimes they don't know what you're talking about. They will be thinking about other things, or maybe they're thinking about money involvement. They don't really know the system. So we talked a lot about the culture and how it links to religion. And another thing I wanted to point out is language barrier. So we usually get a lot of families where they can't speak English, we need an interpreter. It works out well if we have someone face-to-face talking, we have a three-way conversation with someone in person. But most of the time we don't have people face-to-face, and we will have a telephone translator. You can imagine how confusing all of this sometimes is, and you have to support the family who are facing you, and you at the same time try to pass your message via telephone conversation, and all of this causes so much stress to the family when they're at the most low period of their life. And sometimes we do find split family decisions, and this one is really difficult when you have a split family decision, and it's the most difficult time where everybody is in bereavement. You don't want them to have situation where they have to make decision in separate ways. You want them to be together, supporting each other. And in most cases, when you have a split family decision, everybody will support the strong person, and usually the strong person will be the one who will be loudly saying, no, I don't want. And sometimes there's no reason for that, and sometimes it's just linked to the culture. I just wanted to talk about this case study. This is a really good case study that illustrates how the culture sometimes links to religion, and sometimes there's nothing really. You can't really pinpoint what is the issue really. So recently I was in an approach where there was a 14-year-old male. He was admitted out of hospital, cardiac arrest, 30-minute downtime. On admission already, the CT head was showing hypoxic brain injury, on previous history of brain bleed and severe cerebral palsy and dystonia since they were little, like 10 days old. So on the first day of admission, the clinician, they already told the family that this is, you know, your loved one is not going to survive this admission, and we need to start preparing ourselves for withdrawal. That was on the initial admission because the CT scan was really bad. So on day 2, the hospital referred to us. So I went on site. It was very quick because they wanted to have the withdrawal conversation straight away. So I didn't have time to speak to the family or get to know them better. So it was literally like you arrive on site and then you do some on-site assessment and straight away into the family conversation. It was a lovely family. They were, you could tell as soon as you entered the conversation room, they were ready for withdrawal. So both parents, they were Black British, and they, in the meeting, they wanted the religious leader to come in, who was an imam. So you know, we always allowed them to get as many family members to support them, and they came in the room when it was appropriate to approach, because the family was ready for withdrawal at any time. So I approached for organ donation, and the first reaction came from Dad. He understood everything. He was happy to receive all the information, but to get the answer, he looked at the religious leader on the side, waiting to get information from him. Just by reading the reaction in the room, I felt like he wanted to support organ donation, but he wanted more information from his religious leader. So I suggested to give them more time to talk, because I didn't want to intervene, to be there while they are discussing organ donation. So I left the room. After 3 hours, they called me. They received all the information from me, and then they could also tell it back to me. And then the dad told me that, you know what, they don't feel comfortable with organ donation. I asked them what was the reason. They just said, no, we don't feel comfortable, but obviously we're sorry. We understand that he can help so many people because they had all that information, but they just didn't feel comfortable to proceed with organ donation. So in that case, I couldn't really pinpoint whether this was a culture, because you can't just presume that it was culture or religion, but the religion leader was there. I couldn't tell whether they wanted to donate or not, but he was the one who gave them the information they wanted. They had questions, and he answered those ones. And it was a very good thing, because they took all the information. You will find some families, they will not want to hear anything. They're straight to know, but for them, they took all the information. They asked questions, which I thought was really, really good for me to take, a positive thing to take up, so that they've got the information even in the future. If they meet us in the community, they'll be in a position to listen more. And how do we bridge the gap with this situation that we have in London in terms of the culture? On my next slide, I'm talking about education. So as a SNOD, we deliver so many teaching, mainly in the hospital, to clinicians, encouraging them to refer to for any potential donors. We attend community events whenever we have time to educate the member of the community. I'm actually lucky. One of my organ donation chair and my clinical lead, they like community events, so they usually invite me a lot to many community events. Whenever I have the chance, I do attend to raise awareness, because we all know that it's always better to talk about death when at the position of end of life conversation. So it's better to talk about it in the community, where we can discuss organ donation, clear out all the miscommunication that people can have in the community. So we try to attend as many as possible. And also we have the community grant that Mr. Chambers discussed in details earlier on. He's talked about the success of the NHSBT community grant. This is a partnership between NHSBT and local community. And I think finding those organizations to raise awareness and behavior change in terms of organ donation in the community, it's really good. And I would encourage that to carry on, because as SNOD, we don't have much time to go into community events. So it's always good to talk to the community leaders and have a partnership with them in that sense. Thank you very much.
Thank you so much for that. That's really, really helpful, and is also illuminating for us to actually understand what a difficult job you do, but you do it so respectfully and so compassionately, and we're really, really grateful to you. Next speaker is Elizabeth Warrington, who's going to give us a little more insight into the work that specialist nurses do at this really, really difficult time in with patients and community engagement. Thank you.
Hello everyone, are you okay to hear me? Can everybody hear? Yeah, no, that's good. The Midlands, as Umar put it, we are the gap in the middle. Divided, as you can see on my slide, between the east and the west. We incorporate the north and south divide. We've got 6 counties on each side, although NHSBT don't include the greyed out counties within our region. Excluding those, we've got a population of approximately 9 million people, 5 million on the west and 4 on the east. The numbers on this slide are all sort of rounded up just for ease, really. We cover 16 NHS trusts. We've got 4 regional trauma centres with the Queen Elizabeth in Birmingham, Royal Stoke, Coventry, and Nottingham's hospitals. We've also got major trauma at Birmingham Children's Hospitals. So we take a lot of people from outside of region really as well who come to those centres. Probably accounts for our high donation rate. We are one of the most multicultural regions of the UK, excluding Rachel's London. I think we're a bit behind you guys, but probably second nationally, which is why we've been asked to talk on this conference, really. The Midlands has got a sort of strong working class community background, really, shaped by shared labour histories. And that's still quite evident today. There's quite a working class population here, 40-50% the West Midlands, less so on the east, but 30-40%. Our role as a hub for migration has significant influences on our local culture through food, festivals, arts and music. You can see that the main 7 religions are identified. Again, the data comes from the last census. So I suspect that these figures are much higher now. Christianity being the largest religion in our region, followed closely by other or no religion. No religion, those atheists and the agnostics out there, those that aren't sure, is definitely an area that's on the increase. Luckily, this group tends to have a higher rate of organ donation. Our Muslim population is approximately 3% higher than elsewhere in the country, excluding London, of course. We've got major communities in Birmingham, Leicester and Coventry, 10% on the west side of the Midlands, so it is a bit higher, and 4% on the east. Hindus are present wherever we've got large sort of Indian communities, Leicester and Birmingham being the 2 main hotspots. Leicester has one of the highest percentages within the country, 18%. As one area where we are sort of higher than London, really. And even within Birmingham and Coventry, it's at the 6-7% mark. So we do have quite a high Hindu community. The Buddhist community is split across the region, but far less widespread. And Jewish communities, we've got pockets in Birmingham and Nottingham, and it's sort of equal on both sides, really. We can reasonably conclude that over 100 languages and dialects are spoken in at least some of these communities. In terms of our ethnicity, while white British is the major ethnic group within the Midlands, Birmingham and Leicester are what's called plural cities, which means no single group forms a majority. That's because of the large Asian communities. Wolverhampton and Birmingham have a higher community, Black community, including Africans and Caribbeans. In addition to sort of the Windrush generation, we are seeing recent growth with people from Nigeria, Ghana, Somalia settling, and again, primarily in Leicester and Birmingham. And it's no surprise, really, that those 2 cities, Leicester and Birmingham, have some of the lowest organ donation consent rates nationally. Next slide, please, Winnie. So when I was asked to give sort of consent rates on religion and ethnicity, I was a bit lost, to be honest. The stats team kindly put me onto the reporting hub, and I just thought I'd share this for the SNODs across the country that may wonder, you know, what the Sikh, how many Sikh community have been approached within a certain amount of time, what your rates are in your hospitals or your regions. So it's just so you know that that's there and you can all easily use it. It does come with the caveat, really, that smaller numbers are not necessarily accurate. So numbers less than 30 or 40 can be a little bit accurate. And it does limit us to look at religions in terms of these boxes, which can obviously have limitations. Next slide, please. Thanks, Winnie. So I've just had a look at the last 2 complete years data for ethnicity and religion, really. So in terms of ethnicity, it really shows what we already know, that there is a higher amount of people from the white community that are consented, and that our consent rate in all communities is lower than the sort of national consent rate, but higher in those white communities. Next slide, please, Winnie. Broken down into the number of people in religion and consent. Again, the majority from the Christian community, with significantly smaller numbers in the Hindu, other religions and Sikh, and lesser so in the Buddhist, Muslim, unknown and Jewish communities. Next slide, please. This translates into consent rate. So over the last 2 years, it should say 24, 25 on the aqua looking colour. That was my error, I'm afraid. But you can see 100% of Buddhists last year. Then you've got consent rates in the 60% for atheists and Christians, down into the 50s for Hindus and unknowns, into the 40s for the Sikh community and other communities. And then we've got 7%, 0 and 7% for the Muslim community. And there was no Jewish community approached in 23-24, and one approached in 24-25 with a 0% consent rate on that. Overall, you can see that it doesn't necessarily reflect the first slide that I showed in terms of populations. There is some gaps in there, specifically, I would suggest, in the Muslim community. Next slide, please. Now, the last part is about barriers we find to donation in the Midlands, which is difficult, really. I could write a thesis on this, so my 1 minute slide will be particularly limited. Also, these barriers are experienced nationally, and a lot of these areas have already been discussed. I think with having 2 of the most diverse cities in the United Kingdom, with Birmingham and Leicester, these barriers that we can see, or not see, the white's not very clear, I'm afraid, are more commonplace. So, for example, Leicester, 41% of our population here were actually born outside of the United Kingdom. And Birmingham is labelled as super diverse, with half of the population having ethnicity differences. So, of course, that is going to impact on donation rates. With higher ethnicity and diversity, we will, of course, struggle. Sometimes there's concerns, as we know, about trusting our medical systems, respect for bodies after death, organs taken without permission, concerns about how donation affects religious doctrine, the afterlife and the burial rites. And as Rachel's already touched on, decision makers are often outside of the UK, elders perhaps in other countries who the specialist nurses often don't have access to, and sometimes if we do, there can be language barriers, and those conversations can be via telephone. We can't ignore the socio-economic factors in the Midlands as well. Having a higher working class population impacts organ donation, access to healthcare, less education on organ donation, specifically with communities being educated outside of the United Kingdom makes sort of less trust in the NHS, less registrations on the organ donation register, and ultimately less donors. The religious differences are clearly further complicate. Just go back to the last slide, sorry, I just got one more point to make, sorry. The religious differences clearly complicate things for donation more. At our recent EDI Midlands Day, we had Professor Upkar Padisi from the Nissan Centre, and he separated religion quite interestingly into two groups, which I've never heard before, and I thought I'd just share it for interest, really. The Dharmic and the Abrahamic religions. So you can see, hopefully on the screen, the Dharmic religions tend to originate in Indian subcontinent, focus on karma and duty, and the end-of-life practices incorporate cremation and reincarnation. Whereas the Abrahamic religions, who have a shared ancestry and conventionally acknowledge Abraham as the first Jew, focus end-of-life practices on burial and reaching heaven and paradise. While both in theory are supportive of donation, we do find that the Abrahamic faiths can run into more complexities with organ donation, which I think have been covered probably so far in more detail in this cultural conference. A lot to do with the body remaining intact after death and returning to the earth in the way that you were born. Additionally, we need to remember that culture is also made up of customs and ideas and individuals. For example, my husband doesn't want to donate organs because he thinks there's too many people in the world. So it's very difficult as a snod going into a room with a family to know really what you're coming up against. We've recently started a project with Professor Mason in Leicester on Islam and the community, working with one of the advocates, Suleiman Nagdi. And having spoken to him last week, he pointed out that if you're going into a room with a Muslim family, you do need to not think about Islam as a box, but a little bit like what Gurch said about individuals. That person has probably immigrated from different areas of the world, perhaps Asia, Africa, the Middle East, with different beliefs coming from different sects, with different leaders and imams. And I think it's important not to go in with a preconceived idea. What we do find as SNODs in the Midlands, and I don't know whether this is something that's national, but education and engagement with communities does tend to focus more on the Dharmic religions. And I think perhaps we all need to think more about the Abrahamic religions. It's difficult, I know, to give us the time to connect with communities. But the next slide, I think, sort of finishes my presentation quite well, and it was taken from the Ethnicity Transplantation and Transfusion document. The UK has historically framed the communities as having the problem. Communities are very willing to engage with the whole conversation and action, but this has to be led by trusted messengers with tailored messages, which require resource. I think a little bit like what Rachel said, I think we do need more time as SNODs to connect with communities. We've got such knowledge on the subject. I think it could be really helpful. And my last slide, please, Winnie. This is one of the ways in the Midlands that we've been trying to connect with communities. This was a team meeting that we had at the Nishan Centre with a tour of the Sikh Mandir. And it really opened our eyes to Sikhism. But I think our next project, which is about to be sort of rolled out over the next year, is to replicate this in a mosque and connect with Muslim communities. And I think as SNODs, we all need more knowledge on all of these communities, and I'm not sure everybody's got such a mixed bag, and I don't know what the education is now on the the SNOD training, how much is covered in terms of understanding and connecting with communities. Thank you very much. I think that's done.
Thank you so much for that, Liz. That again, I think reinforces some messages for us. It's about NHSBT's actually scrupulous data collection. I mean, I think we have a lot to take pride in that. And also the pride and privilege that both you and Rachel have shared in your job. You're right, you get a very short period of time with families, but it's very clear from what both of you have said that you always keep the families at the center of your conversations, and you do it so respectfully and compassionately. So thank you so much for that. I will move on to our next speaker. Thank you so much, Rachel and Liz. Our next speaker is Shivum Kakkad, and we are so grateful to him, Winnie, John, Amy, Lucy, Joanne, and myself, for coming and sharing with us the story of his family. Shivam's family, at the time of their greatest grief, showed exemplary generosity and courage in saying yes to organ donation, and we're so grateful to him for coming and sharing their story with us today. Over to you, Shivam.
Thank you. Thank you so much. Can everyone hear me? Is that working? Can you hear me? Okay, good. Yes, thank you so much for this conference. I think it's always fantastic. It's the conversation we've been having for a long time. Is it possible for me to share a video, or is it a little bit late, Winnie?
You can share.
All right, let me just share this lovely video.
My dad was always my safety net. I never imagined my life without him. He loved kids. I regret that he never had grandkids, but you saw it with this little fur baby, how much he loved kids. Woke up at 7 a.m. and I heard it, oh, come here, little baby, come here, little baby. And I thought, what the hell are they talking to? Went down and saw him kissing, cuddling Luigi, and I was like, this is a man with a lot of love to give.
There was no place like home for Dad, and home was where his family was and friends, and he's got a huge group of friends. When he passed away, we had hundreds and hundreds of people coming to the house. He was a very happy and funny man. A horrendous laugh as well. I miss it. I miss his laugh. When they told us there's no options left, I think the first thing we said, in fact, okay, well, let's get organ donation.
The difficult news we had that day, 2 other people were getting phenomenal news that they've been waiting for. So there's some balance and karma in the world.
That felt normal to us. It just felt like someone's got to benefit from this in the end of the day. And it's not us, so why not someone else?
It is something people should talk about, because you never know when something's going to happen. At least if you've had that discussion, you know the person's own individual wishes. He helped 2 people directly, but you can't measure how many other people along the road who have now had conversations from knowing that he was a donor.
None of it really makes sense, but the only thing that did make sense was this.
If you are in that situation, there's very little positive to take, but here is a positive. Here's a chance to do something good right when everything else feels bad. And for the donor themselves and even for the family, you know, there's some solace in that. So I would really encourage everyone to have that conversation.
So there we go. Sorry, thank you. Hopefully that showed everyone a little bit. That my father passed away, like I said, in 2019. Unfortunately, he suffered a cardiac arrest just in the morning around 6 o'clock in the morning. I think it was about 5:30, 6 o'clock in the morning. And yeah, I think at the time, obviously for me, I was 29 years old, so it was I was lucky that at that moment I was living at home with my parents, so I was there to be there to kind of go through this with my mum, but I think nothing really prepares you for that, right? Nothing can prepare you to lose a family member in front of your eyes. There's some solace in the fact that it was a cardiac arrest, and we hopefully hear that he didn't feel pain, so he went through that without feeling pain, which so many people go through these days with so many different illnesses and difficulties that they may go through. So he always used to say when he was younger, when he dies, he's going to die like that.